Weston Galleria for hosting this, which for many of us is our first in-person event in a couple of years. And I am honored to be, along with Lisa Casey, co-director of this conference. Reminder to log into EventMobi, your EventMobi app. Lewis in his talk has some polls he's pulling up. If you go to main stage, you will see a polls tab to click. So let's get started. I want to start out with my dear friend. He wanted me just to introduce him as a small town country GI doc. I think he's done many more things. Lewis Wilson is our TSGE president, having completed his MD at UT Southwestern, residency in Iowa City, fellowship at UAB. Lewis then came to Wichita Falls in '97, has been there ever since, living in the house of the first female aviator and oil person, if I got that right. So Lewis has written an uncountable number of articles that have helped us so much in practice management. He is the former chair of the ACG Practice Management Committee and is the upcoming chair of the Legislative and Public Policy Committee. Lewis is starting us out with a bang and not a whimper, to quote T.S. Eliot. He's going to talk about what we knew was going to be our first lecture, and that is what the hell has just happened over the past 18 months. So without further ado, Lewis, tell us what the hell happened.
How's everybody feeling today? Good. Anybody have a fever? Cough? Shortness of breath? Depression? Anxiety? PTSD? Are you thrilled to be here? Yeah, all those things, right? So when they gave me this talk, honestly, this has been the hardest talk to prepare for, I think, that I've ever had. It sounded so simple when they asked me to do it. Can you just give us a talk of what the hell just happened? My team is at ACG was responsible for surveys through the pandemic, and so they figured they could ask me what just happened. So let's get started. So let's see if has everybody been on the polls yet? There's 4 questions on the app. You can answer them all now, one after the other. You have to answer one to get to the next. And the first is a kind of a question to see how honest you are. Prior to the pandemic, do you know who Anthony Fauci was? Okay, so we have a few dishonest people in there. If I was going to sell this as a script in Hollywood, it might sound something like this. Scientists, slightly deranged scientists, crawling around in caves in southern China, obtained dangerous viruses from bat guana and took them back to their lab where they manipulated those viruses, and then they, through gain of function research, made them more lethal. And then when an accidental release from the viral lab occurred, it infected not just the scientists, but people around the lab. And the Chinese Communist Party suppressed that information and tried to hide it just long enough for a worldwide pandemic to occur, killing tens of millions of people and causing political and economic chaos, panic, and confusion. You say, well, I already seen that movie, Lewis. Right? I say, no, actually you haven't. This is a real story about a real contagion, and not just one contagion, but 2. One by a virus and one of the mind. And that's where we are now. The main characters I'm going to talk about today are contagion, credibility and the crisis therein, and resilience and what it means, and do we have it? And it's been a hell of a ride, right? Except this is that ride you go to at the park and you regret getting on it, you know, those rides, and then you're like, can I get off, please? And then they shut the gate and you got to go around again. And that's where we are. We haven't gotten off this yet. So we're so fresh. The wounds are fresh. We're all still in this problem. So maybe it's too early to talk about. Should we wait a little while to talk about this? But we've been doing this for 20 months. So I think it's appropriate to try to learn from what we've done so far, right and wrong, and maybe try to do something different about the future. I think it's time to do that, and that's what I'm going to try to do today. And it does start at the beginning. I mentioned a credibility crisis. How did that start? Well, it started right at the beginning when people naturally wanted to know, where did this virus come from? And they were told some story by, authorities that it came from a wet lab, from somebody, or something. And it just didn't make sense to people. And to say otherwise and to ask those questions was censored and suppressed. That doesn't engender trust. So the Biden administration called for a intelligence community briefing 90 days that was due August 24th. But what they came out with, right, turned out to be this watered down, declassified summary letter that basically says, well, we still can't say because we don't have cooperation from the Chinese government. Meanwhile, the minority members of the House Foreign Affairs Committee also released a report, which is actually really fun to read. It's 83 pages long, 227 references, and gives a detailed timeline with lots of fascinating intelligence, including sort of political intrigue and virology and a variety of things. And I recommend that you read it. But basically what they're saying is that these viruses, that the evidence says these viruses were extracted from caves sometime between 2012 and 2015. And that sometime around September 12th, when the lab was locked down, there was an accidental release from the Wuhan Institute of Virology. And that unfortunately for the world, in October, Wuhan happened to be the host of the International World Military Games, which involves thousands of athletes, by the way, and over 200,000 volunteers. Since then, at least 4 countries, Italy, France, Sweden, and Brazil, who had sent delegations, have RNA-proven cases between November and December of this virus. So the virus came from southern China, but actually was somehow caused an infection 1,000 miles away. What is Wuhan? I didn't know before the pandemic, right? But Wuhan is a gigantic metropolis, larger than Chicago and New York combined, dozens of universities. So it's a giant place. Well, what happened when this all started, as far as we knew, was breathtaking. December 31st, 2019 was the first time Chinese officials admitted they had this unknown infection going on. And just a few days later, the United States announced it had its first case. On January 7th, it was identified as this virus. And then on January 17th, just a couple weeks later, they start screening at airports. January 23rd, China placed Wuhan under quarantine, although it's quite clear that actually Wuhan was under quarantine long before that. On January 27th, the task force of the president starts meeting every single day. On January 30th, there was declared as a global health emergency. On January 31st, the White House announced it was going to ban entry from foreign nationals who travel to China. That first year was breathtaking. So many milestones, so much happened. It's really hard to put it on perspective. A lot of failures and then a lot of successes, including March 27th already. The CARES Act was passed, which brought us all a lot of necessary relief. Nevertheless, the virus took off, and then we had some, triumphs as it related to therapeutics, and finally the vaccines that same year. The thing that affected us all the most was this so-called lockdown. On March 16th, the White House announced its COVID task force social distancing guidelines, 15 days to flatten the curve. But what this became was a lot longer than 15 days and different all across the country. Disorganized, but basically state and local lockdowns of a variety of degrees that have lasted all the way up until early of 2021. This affected our lives. Early on, there were so many questions, so much we didn't know. How was the virus spread? How many people had already been infected? We didn't even know. How can you function without knowing these things? Who's at risk? How do you count and keep track of cases or deaths? How we decided to do that has impacted us mentally all the way until today and in our responses. Should we trust the predictive models that the policymakers used? Should we require masks for the first time in America? Will lockdowns slow the spread? Should the public response, take into account only suppression of the virus, or should it take into account economic and societal harms? What would those harms be? How do you weigh costs and benefits of something when you don't know either one? So what happened was this path to confusion and panic that we're all dealing with all the time right now. It started with terrifying models. The Imperial College model predicted 40 million dead in 2020 and 2.2 million dead in the United States. Shortly thereafter, on March 26, the Institute of Health Metrics and Evaluation at University of Washington released its model. This was the model that we ended up using predominantly in the United States. It predicted a sharp and unstoppable rise of the virus and a requirement for far more beds and ICU beds that were available. We had to learn this new vocabulary of risk mitigation, right? Isolation, quarantine, defining these things, PPE, essential workers, whoever they are, and unessential workers, whoever they are. We had closures, social distancing, mitigation, and mostly this idea of flattening the curve. Then the media was in full alert. It was not just, weekly updates or monthly updates or list review. It was hourly updates, predominantly related to cases, test positivity, rumors, opinions. Fear peddling and clickbait went viral. I love this one. Who among us today will be dead by next month? Your cashier at your grocery store, your best friend, your child. The New York Times devoted, hasn't done this since World War II, the entire front page on May 24th to names of people killed by COVID. As Chuck Owen says, we had lots of numerators without denominators, headlines without context. Everyone became an expert. In late March, Governor Andrew Cuomo said the state needed 40,000 ventilators. Everyone is entitled to their opinion, he said, but I do not operate here on opinion. I operate on facts and on data and on numbers and on projections. They never needed more than 4,000 ventilators. Not just the media, but the public then clamored for lockdowns. It was not just something we imposed on us. We asked for it. We got involved. You may remember on April 1st, I sent out this memo to the members of 10 things you need to be doing right now in your practice. Things like renegotiating your PSA with your hospital. If you did that, you know the value, right? But a variety of other things, having regular meetings, taking care of yourself, supporting your staff, doing everything that it took to keep endoscopy available for your community. A week later, this was released by the ACG nationwide from me as chairman of the Practice Management Committee. During this thing, we had two choices, basically. The idea of mitigation on one side or total viral suppression on the other. So the mitigation side would have been things like isolating suspected cases, quarantine known exposures, targeting, protecting the vulnerable, so-called focused protection, right? Then the total suppression round is social distancing for everyone, sheltering in place for all non-essential workers, widespread economic lockdowns, etc. That's the path we ended up choosing, at least in 2020. During this time, the ACG task force, called the Endoscopy Resumption Task Force, tasked me and a team to survey the membership. We surveyed the membership 3 times during 2020, each exactly 2 weeks long, and you can see when those occurred. We then had a series of webinars. As you can see, now there have been 6 altogether, updating membership. The surveys were very successful, actually. We reached a lot of people, a lot of doctors, but across a lot of different practice types, as you can see, in 47 states and Puerto Rico. We surveyed things like practice characteristics, endoscopy practice, outpatient, hospital, and financial outcomes. The majority of doctors shut down. About 60% shut down for at least 2 weeks. But by January, all the results I'm going to show you, by January, most of them had reopened. Some in January of 2021, as you can see, had actually shut down, reopened, and shut down again. You can add these, I want to show how you can kind of add these surveys together over time to create a narrative or a story. For instance, you can see in April, we had a significant PPE gap. 70% of us were using N95s or trying to use N95s, but very few had them available. And you can see that gap close. All right, poll question. What best describes the current mask requirements and for providers and staff at your office? Can you show those results? Okay. No, that's the... Keep going. Go back. Can you show the... All right. Everyone's been vaccinated. How about that? Yeah, so most people admitted they didn't know Anthony Fauci. Next. Everyone, 100% of y'all have been vaccinated. Next. Do you mandate the vaccine? Most do right now, 80%. Next. What percentage is telemedicine? Less than 25% for the majority. Okay, thank you. We'll go back. Those will be put in context here shortly. Ppis at the office. So in January, most were requiring surgical masks, 70%, any face covering by 15%, N95s by 13%. This was a year of masks. We have never seen anything like this in the United States. Why is it the year of masks? We've seen everything. We've seen, surgical masks, paper masks, homemade masks, cloth masks, message masks, right? And of course, the star of the show, the N95 mask. Why is this now a big recommendation? Why haven't we heard of this before? Why is it? Well, it's fascinating because in 2017 and in 2019, you can see the most recent CDC and World Health Organization guidelines as it relates to pandemic response recommendations. They virtually did not even mention masks for the public in these documents. Decades of research have shown them to be ineffective. In 2017, as you can see, they said, quote, they might be worn by ill persons, and also there is little evidence supports the use of face masks by well persons in community settings. The WHO said, quality of evidence, it says there is moderate overall evidence quality, that evidence that face masks do not have substantial effect on the transmission of influenza. Now, we've all been through this ritual, the N95, fitting and testing at our facilities. And we've all learned that wearing an N95 mask properly, for the most part, is extremely difficult to do. It's not so easy. I wore an N95 mask for months that turned out that failed the testing. Well, these were designed for short-term protection in an environment where you might be exposed, not to be lived in. So as healthcare providers, what is the evidence? We know that the physical properties of N95 masks can filter SARS. Those little 2 to 5 micron particles that carry the virus are filtered 95% of the time by N95 masks. But in vivo, when you study it in healthcare workers, it doesn't seem to make a difference, whether it's N95 masks or surgical masks. What does that mean? Probably means it's hard to wear them right. Cloth masks have repeatedly been shown to be of no value and potentially of harm. Now, this is in the CDC website about how to wear a mask, and it highlights a couple of things. In order for a mask of your people of your patients and the public to be working, it has to have some things. It has to seal properly, right? It has to filter the air, not just redirect it around the edges, right? And it has to be clean. It has to be managed. The masks that are being worn in public are filthy, especially by children. I wonder why they don't work. There have been in the COVID era several studies, not very many. I scoured the earth for these studies. Why are we doing, public mask mandates? Here's a study in Denmark, peer-reviewed, adequately powered, and published. And it showed basically that in Denmark, 4,000 do not surgical masks, provided the masks, taught them how to wear them, did not make a statistical difference. Then we had this study that was recently released, not peer-reviewed, preprint working paper by an organization called Innovation for Poverty Action. And they did a big study in rural Bangladesh and 600 villages. They take 300 villages where they taught everybody to wear surgical masks, provided the surgical mask, put monitors in the streets to see how it's going, used elders in the villages to model the use of these masks, etc. And in the villages where they did these interventions, mask wearing, proper mask went from 13 to 42%. And the number of cases, symptomatic COVID-like illnesses, went from 13,893 in the control group, and 13,273, 620 less, in the intervention group. In 5 months, those differences were gone. So there's two sides to every story, right? Masks should work. They should be simple. It's not so simple. They're mostly symbolic. The more they fail, the more we need them. But the truth is that it's a psychological remedy for a largely psychological part of our pandemic. What about the vaccines? Why did we go so sideways on these? It's crazy, right? I never had so many patients reject my recommendations in my entire career. It's weird. We already know the answer to this question. 100% of you are vaccinated. So you should feel good about that, I think. And 80% are now mandating masks. As of January of 2021, 93%, in those 2 weeks, 93% of doctors surveyed were already vaccinated, even then. And 70% were requiring their staff to become vaccinated, but were not tracking it. And so, anyway, let's go to the messaging, right? When we started this off, we were all excited about these vaccines, and rightly so, the most effective thing we've done in 2020, right, for this. And they were, touted as the elixirs, the magic elixirs of freedom. We were going to be able to take our masks off, go back to work, go to football games, weddings, see our grandparents, all that stuff. And most Americans have listened. As of September 13th, these are the statistics on vaccination. About 210 million Americans have been vaccinated fully. That's a lot. 179 million are fully vaccinated. And you can see the ones that were vaccinated with the one-shot regimen versus the two-shot regimen. And this is percentages of all Americans. And they probably have helped a lot. As you can see in this, again, mathematical modeling, because that's all we have. We don't have a randomized controlled trial for the whole population. But you would think, but it looks like that with Delta, we probably would have had a much, much worse outcome had it not been for these vaccinations. But there's no question the vaccines are decreasing in effectiveness in a fairly dramatic way. According to the CDC, from their Heroes Recover cohort, between December 14th of 2020, we had 91%, and by August 14th, it's 66% effectiveness at the prevention of symptomatic and asymptomatic infection. So our message has changed. Now we're saying we expect that they have decreased in effectiveness in the Delta era, but they protect against hospitalization and death. Nevertheless, people have heard a lot, and they're moving on. And they're not listening, and that's a problem. Back to the surveys. More things, patient volume, staffing, PPE in the office, telemedicine. We were a lot more put yourself back at the beginning of last year. We were really pretty optimistic. Believe it or not, 42% in April thought they would be at full volume in 30 days, right? Yet only 20% were at full volume by 60 days. In fact, only 40% are at full volume all the way until January. Telemedicine was a very interesting story. Breathtaking how rapidly American doctors took this on. You know that right now, a lot fewer, less than 25% of you are using this most of the time, though. So prior to the pandemic, almost no one was using it. It rapidly fell off. So you can see in April, 67% said they were using it more than 75% of the time, and by January, it was 19%, and that's probably continued to fall off. Most doctors said they were planning on continuing to use it, but only if reimbursement was kept the same. Financial outcomes, most doctors had less income, as you know. 58% said they earned in that about 3/4 of what they did the year before. Some doctors, about 6%, earned more in 2020 than usual. The differences are interesting. Doctors in solo practice were significantly more likely to say they lost money. And doctors in hospital employed or academic practices made more than usual. Did all this shelter in place and lockdown help? So the National Bureau of Economic Research produced this very excellent report analyzing the effect of shelter-in-place policies on excess deaths from COVID in 43 countries, and all 50 states failed to find that any of those countries or U.S. states that implemented these earlier had any decreased excess deaths. and failed to observe differences in excess death trends before and after the implementation. They made this very interesting statement. Even if shelter-in-place policies reduce COVID-19 transmission, their impact on overall health is unclear. Likely, these things had several important unintended consequences. That is the key phrase. What might those be? Get ready. First of all, SIP, shelter-in-place, there was complex changes in healthcare utilization because of them that actually worked against their effectiveness. And there was actually a decrease in health equity. Shelter-in-place caused economic devastation that caused hunger and deprivation around the world and in the United States. Dramatic rise in child abuse. Increase in domestic violence. Dramatic increase in serious mental health issues. This is really a big deal. Shockingly, as you look through this, notice that 25% of Americans between the ages of 18 and 24 considered suicide during this time, against a backdrop of 6% usually. What the hell? What about physicians and providers? Detrimental impact on the mental health of us, significantly. What about obesity? There's a mental health, there's a public health crisis. A dramatic increase in obesity, in childhood obesity. During last year, children 5 to 11 had an average overall weight gain of 3.7 kilograms. More weight gain in that 1 year than in the previous 20 years combined. Significant delays in medical care, cardiac care, cancer care. What about colorectal cancer screening and mammography? They decreased dramatically. Is that really important in face of a pandemic? Let's put it in context. Colorectal cancer and breast cancer generate 400,000 cases, 90,000 deaths a year. Following COVID, the National Emergency Declaration, there was a 90% reduction in colonoscopy and mammography. Now we're seeing what paid off is that now there are studies coming out, this one just last week, showing that patients who were diagnosed after this had more advanced disease, resulting in thousands of more cancer deaths. You've heard this story, the crazy increase in opioid overdoses. What's going on with that? How important is it? Let's put it in perspective. When you compare 2019 to 2020, there were 77,000 more funerals. That's how many more people died, according to the CDC, than in 2019. Not 375,000, right? The life expectancy of Americans dropped by a year last year. Overdoses are a little part of that equation. Why? There were 23,000 more people died of overdose in 2020 than in 2019, and 2019 was already the highest year ever. The average age was 43 and a half, over 3 million life years lost. By the way, 3,000 more murders in 2020 than 2019, affecting young people. On the other hand, COVID was a disease that focused its rage on the elderly. The median age of death in COVID-19 was between 80 and 82 worldwide. Only 50% of deaths can be considered preventable. 43% of American deaths due to COVID occurred in nursing homes. 43%. What about the obesity situation? It exposed our public health catastrophe of obesity. No question about it. It's the single most important independent risk factor for death by COVID. In Wichita Falls, Wichita County, I studied this. If you look at the, quote, younger deaths, we had 19 younger deaths prior to August 31st of this year. I reviewed all of those charts. The average BMI was 46.6 of our younger deaths. 5 of 19 had BMIs over 50. Crazy. So public health is supposed to protect the health of the public, right? It's supposed to improve our health, not just protect us from a virus. This is a great quote from Donald Henderson. He would roll over in his grave, the legendary dean of Johns Hopkins School of Public Health and recipient of the Presidential Medal of Freedom. He said, experience has shown us that communities face epidemics and other adverse events respond best with the least anxiety when normal social function in the community is least disrupted. Martin Kulldorff over at Harvard, current professor of medicine, said it was a strange time to be a public health scientist when so many have thrown public health principles out the window and the working class under the bus. Koldorf, Gupta, and Bhattacharya from Harvard, Stanford, and Yale wrote this Great Barrington Declaration, which has now been signed by over 14,000 public health professionals and 850,000 people. It's worth reading, talking about what is focused protection. So why did we go down the total suppression route? Well, you can't ignore social group dynamics and psychology. I'm going to highlight one thing about that. Carl Jung once said in 1933, it's become more obvious that it is not starvation, microbes, or cancer, but man himself who is the greatest danger, because he has no adaptation adequate to protect him against psychological epidemics, which are incidentally more devastating in their effect than the greatest natural catastrophes. So I'm going to talk about one of those dynamics, and that's groupthink. Very important. I think it's illustrative. What is groupthink? We all say the word. What does it really mean? It was a word from Yale University psychologist Irving Yannis, studying U.S. political fiascos such as the Bay of Pigs, Watergate, military invasion of Iraq. And he described it as, quote, a recurring pattern of dysfunctional decision-making by assemblies of otherwise intelligent people in those administrations. So in groupthink, there's heavy pressure on individuals working in a group to avoid raising controversial issues or alternative solutions. There's a loss of individual creativity, uniqueness, and independent thinking. Here are the rules. The members share a common viewpoint or belief not entirely based on data or objective or provable data, and may be made up of partial truths. Then the members of the group substitute consensus for objective reality. An in-group is formed around an in-leader often, and then an out-group is formed. The in-group seeks to diminish or disregard evidence that contradicts its views, and the out-group is professionally and, more importantly, personally marginalized. So this in-group, out-group dynamics, which has gone viral in America, is like this. The in-group has this illusion of inflated sense of certainty of their decisions, while the out-group, and then starts to underrate the abilities of its detractors, right? Then personally marginalizing, often dehumanizing them, to discredit them and control the narrative. This gets a lot worse in what we have now, a panic community. Situational context is very important. External threats, time pressures, recent failures, increased groupthink. Highly stressful events causing, quote, high-stake decisions that lead members into irrational choices. And that is a lot worse, and we know why. Media, social media, a worldwide continuous conversation. This is the rise of social media since H1N1 in 2009. So if you were going to create a panic, how would you do it? Well, you would obsess constantly over cases. You would overstimulate the conversation. You would rely on frightening predictive models. You would damage your credibility right from the start. You would treat people like idiots, providing conflicting messages, better yet, be a hypocrite. And then you would try to censor them. Yet these are the challenges that we have to practice medicine in. A hyper-connected world, and healthcare is on the brink. Increased industrialization, mechanization, corporate practice of medicine, productivity pressures, hyper-connected environment, right? Influences on the release of information. I want to say something real quick about consolidation. During 2019, consolidation was everywhere. 2020 kind of took a break, but I think our attitude has changed and consolidation has taken off. It's something all of you are talking about, so I wanted to say something about it. These are all the platforms of private equity in the United States. Texas, right now there are 9 private equity platforms. Thank you, Scott Fraser, for this slide that he released in the ACG special grand rounds. But most people expect the future to look more like dermatology, where there are 40 platforms right now, currently 9. Texas has led the way. Because of the breathtaking expansion and growth of GI Alliance, Texas is probably the #1 state, unquestionably, in MSO activity. You can see that here. Also, doctors are much more interested in this. So just between November of 2020 and then, March of 20 and then March of 2021, the number of doctors said they were considering joining an MSO has gone from 19% to 33%. What about TSGE? Where we are right now is so important related to all these things. TSGE is built on these things, in my opinion: education, collaboration, advocacy, and the community that we share. We represent GI doctors all across the state of Texas trying to do better. We're approaching our record. Right now we have a record membership. We need to do even better. Our advocacy, despite the pandemic, has been extremely successful. This year alone, our priority bill getting coverage for colorectal cancer screening in Texas at age 45. Bills protecting us against unfair pre-authorization rules. You'll be hearing more about that at lunch. And bills preventing taxation of outsourced medical billing services. Our committees are our lifeblood. They've expanded dramatically. There's plenty of opportunity for your involvement in those committees. We're addressing the pressing issues that matter to you. One word about resilience. It's not guaranteed. It's not enough to just say you're resilient. You have to embrace the principles of anti-fragility. Things that are anti-fragile get stronger with stress. They get stronger and better with challenge. You can't use short-term solutions and apply them to long-term problems. You have to recognize what the real long-term problems is. Examples: non-essential workers are essential. Elective healthcare is not elective. It can only be achieved if you address the psychological components. If we are psychologically damaged, if our patients are psychologically damaged, you can't be resilient. And you have to focus on the real risk factors that you can do something about. Obesity, for instance. Madame Curie said this: nothing in life, in 2011, nothing in life is to be feared, it is only to be understood. Now is the time to understand more so we may fear less. What we learned: slow the conversation down, doctors. Encourage open conversation, admit what you don't know. Always balance expert opinions with opposing views. Be careful about using consensus as data. Focus on care for the vulnerable while minimizing disruptions. Treat predictive models with skepticism. Accept media reports with a great deal of caution. Give people liberty as much as possible. Contagion, unquestionably. The virus is contagious, so is the mind. Credibility, damaged. Needed, we have to have it. Resilience is being tested. The virus is resilient. Will we be? I think so. We have to learn. TSGE is a big part of that. Thank you all for coming. God bless you.
Louis, thank you. What a wonderful way to start out the morning. A lot to think about. He and I have talked. That speech by Faulkner was his Nobel Prize speech, and I loved it. Heard it first in high school. The last line that we need to remember is that we have to think that humankind will not endure, it will prevail. And your message helps us to prevail. Let's move right ahead to our upper GI and esophagus talks. Lisa Casey and Ben Havman are going to moderate with Drs. Speckler, Lacey, and Kedia. Thank you.
Thanks so much, Chuck. Appreciate it. Good morning. It's wonderful to see all your beautiful faces here in the room together in person for the first time in too long. And I want to thank Dr. Wilson for that wonderful speech and for his leadership and steadying the ship through choppy waters, to say the least. I'm Ben Havman from Austin Gastroenterology. I also want to thank my colleague here, Dr. Casey, for agreeing to take on the mantle of program coordinator along with Dr. Owens, and congratulate her on a phenomenal curriculum.
Welcome, everybody. We're really happy to see you all here and also online, new friends, old friends. And Want to have a couple of things really quick to mention as far as housekeeping. There is an online chat for questions for our virtual visitors, and also in person, we ask you to come to the floor mics, which are on the sides here. We'll have a question and answer session for all of our speakers at the end. The surveys for the CME are in Event Mobi, and it'll pop up and remind you repeatedly. Also, don't forget to visit our exhibition halls during the breaks, because we have a lot of exhibitors that we really appreciate coming out during this complicated year. So it is my pleasure to introduce Stu Speckler. He is well known to a lot of us, both for a lot of extensive years of research and publications in esophageal disorders, and also for years of mentoring a lot of us through our training. Currently, he is the chief of the division of gastroenterology at Baylor University Medical Center here in Dallas, and the co-director for the Center for Esophageal Disorders or Diseases, and the co-director of the Center for Esophageal Research. He is going to speak to us about refractory GERD, how to conceptualize and manage.
Well, thank you, Lisa. I do want to thank the members of the Planning Committee. It's really a pleasure to be here with you all in person again. This is fantastic. Dr. Wilson, just absolutely loved your talk. You're a very tough act to follow. But let's consider this man. Okay, I know you've seen this man in practice. He's a 53-year-old man. He complains of heartburn for the past few months. He's tried several over-the-counter medications, Tums, famotidine, omeprazole. None of them have relieved his heartburn. So why hasn't he responded to medical therapy? He's taking a PPI, and PPIs are the best drugs that we have for blocking gastric acid secretion and treating GERD. Here's a large study comparing the efficacy of two PPIs, esomeprazole and lansoprazole, for healing GERD in patients who had reflux esophagitis. And I show you this slide not to emphasize the marginal statistical advantage of one PPI over another, but rather to show just how similar they really are. With PPIs, you can expect healing rates for esophagitis in the range of 90%. But at 4 weeks, only about 60% of patients report complete resolution of their GERD symptoms, so 40% say they still have GERD symptoms. So PPIs are great for healing reflux esophagitis, but only okay for relieving symptoms. Surveys find that only 58% of patients taking PPIs for heartburn report complete satisfaction with therapy, and Ppi Refractory Gerd, that's the most common GERD-related referral to gastroenterologists. But is Ppi Refractory Gerd really that common? These are patients who've been diagnosed by a physician, or they're self-diagnosed as having GERD, and what they report as PPI refractory GERD symptoms might not be GERD symptoms at all. So, for example, patients on PPIs may still be bothered by bloating, early satiation, and dyspepsia. Those are frequent in GERD patients, but they probably have nothing to do with acid reflux. Or patients may be treated with PPIs for atypical GERD symptoms like cough, hoarseness, and throat clearing, which might be due to GERD, but often are not. And typical GERD symptoms like heartburn and regurgitation, those are far more likely to respond to PPIs than atypical symptoms. But even for the typical GERD symptoms, response to a PPI trial is not a sensitive or specific test for GERD. So today, let's just focus on the typical GERD symptom of heartburn. So what are the potential mechanisms for PPI refractory heartburn? Well, first, the symptoms might not be esophageal at all. An extraesophageal disorder, like heart disease or biliary tract disease, might cause a sensation of heartburn. Now, often there are clues to that in the medical history. Next, there could be a non-GERD esophageal disorder, like eosinophilic esophagitis or achalasia, and that can cause the sensation of heartburn. And those are disorders that can be identified by endoscopy, with biopsy, and by manometry. Now, a third possibility is that the heartburn is reflux related. Now, here there's two possible conditions. First, abnormal acid reflux might persist, even though the patient's taking PPIs. They don't always normalize acid reflux. And of course, PPIs don't do anything to correct the defective anti-reflux mechanism in GERD patients. So even if the PPIs have normalized acid reflux, persistent reflux events might evoke a sensation of heartburn. And that's a condition we call reflux hypersensitivity. And we can use multi-channel intraluminal impedance combined with pH monitoring to identify patients with reflux hypersensitivity. And finally, when all these other possibilities have been excluded, you can conclude that this patient has functional heartburn. So let's consider the first possibility that an extraesophageal disorder like heart disease might be causing heartburn. Now, the angina of heart disease might be described as burning in character, and in theory, it could be incorrectly diagnosed as heartburn due to GERD. You know, there are surprisingly few reports that document that error. Now, heartburn due to GERD has some very typical features. It causes burning in the retrosternal area. It rolls up the chest. It's often described with the wave of an open hand. It's precipitated by foods that induce reflux or irritate a GERD-damaged esophagus, and it's temporarily released by antacids. Now, it's not clear how often heart disease truly causes burning chest pain that you couldn't distinguish from the heartburn of GERD by a careful history. Frankly, I'm not sure that ever really happens. Now, patients certainly can misunderstand what's meant by the term heartburn, and they may tell their physicians they have heartburn when they're in fact experiencing typical anginal symptoms of squeezing chest pain brought on by exercise. That happens surprisingly often. I see patients all the time complaining of heartburn, and I'll go, oh my God, you got to see a cardiologist immediately. If you accept a patient's history at face value without asking for a description of the heartburn, then angina due to heart disease might well be confused with GERD. So confirm that patients who say they have heartburn really have heartburn. And if there's any question, be sure to exclude heart disease. I mean, heartburn won't kill you. Heart disease certainly can. Now, what about that second possibility, that a non-GERD esophageal disorder like eosinophilic esophagitis or achalasia is causing heartburn? Now, those are disorders that truly can cause heartburn that can't be distinguished from the heartburn of GERD. But we can find those with endoscopy and with esophageal manometry. So here's what we see by endoscopy that can help in the diagnosis of these patients. You might find evidence of reflux esophagitis, which we grade with this Los Angeles system. Or we might see the typical changes of eosinophilic esophagitis, like rings, furrows, and exudates. However, PPIs can eliminate every one of those endoscopic features. Now, endoscopists don't always advise their patients to stop PPIs before doing a diagnostic endoscopy, and I think that really compromises the value of the test. For patients with PPI refractory heartburn, I think you should perform your diagnostic endoscopy after stopping PPIs for 2 to 4 weeks. If you don't stop PPIs, you cannot exclude a diagnosis of eosinophilic esophagitis. Okay, that's really should be fairly obvious. I think you use PPIs to treat EOE. If you have a patient on PPIs, how are you going to find eosinophilic esophagitis? And you're going to have to do further testing to establish a diagnosis of GERD, and you really can't make a diagnosis of NERD until you've done an endoscopy off PPIs. Now let's consider this PPI refractory heartburn that is reflux related. And here again, 2 possibilities. First, you have abnormal acid reflux persisting despite PPI therapy. Or you can have normal acid reflux, but the persistent events evoke the symptom of heartburn, and that's reflux hypersensitivity. But consider the first one. How often does that abnormal acid reflux persist, even though you have your patient on PPIs? Well, in this study, the investigators reviewed pH monitoring studies that were done for patients who had GERD symptoms unresponsive to PPIs. And they divided the patients into 2 groups, those with typical GERD symptoms on the left, like heartburn and regurgitation, those with extraesophageal GERD symptoms. Now, for patients who took PPIs once a day, and those are the orange bars, About 30% of both groups still had abnormal acid reflux. So it's not uncommon for patients who take PPIs once daily to have persistently abnormal acid reflux. But when the patients are taking a PPI twice daily, only 1 to 7% still have abnormal acid reflux. So for patients on a PPI twice a day, fewer than 10% have persistently abnormal acid reflux. Now, what about this reflux hypersensitivity? This is the condition in which acid reflux has normalized. It hasn't disappeared, but it's normalized. But persistent reflux events, which might be acidic, non-acidic, or even alkaline, evoke heartburn. Now, we can diagnose that condition with combined impedance pH monitoring. Now, by convention, esophageal pH monitoring identifies acid reflux only when that pH falls below 4. But impedance monitoring identifies all reflux episodes, whether they're acidic, non-acidic, or weakly acidic, or alkaline. And reflux hypersensitivity, again, this is the condition in which you have normal acid exposure, but the reflux episodes, whatever they are, acidic, weakly acidic, or alkaline, they're causing heartburn, or at least they're associated with heartburn. Now, the Rome 4 committee tells us that reflux hypersensitivity is a functional disorder. In other words, they say this is more a sensation problem than a plumbing problem. I'm not really sure that's a useful concept, and we'll get back to that point in a moment. Now, transient LES relaxation, that's the major mechanism for gastroesophageal reflux. That's both in normal individuals and in patients with GERD. Transient LES relaxation, this is LES relaxation that's not induced by swallowing. It lasts longer than 10 seconds. It's not accompanied by peristalsis. And neurons that have GABA B receptors can inhibit that transient LES relaxation. And we can exploit that feature by using the agent baclofen, which is a GABA B antagonist. Baclofen inhibits LES relaxation, these transient ones, and so it might prevent reflux. Unfortunately, this is an agent that has frequent side effects and few data document that it's effective. Now, Rome 4 considers reflux hypersensitivity functional, and so neuromodulator antidepressant medicines like tricyclics, SSRIs, SNRIs, they've been used to dampen visceral hypersensitivity. These are agents that block the so-called pain gate that relays pain signals from the GI tract to the brain. Unfortunately, these antidepressants have frequent side effects, and really few data document their efficacy in refractory GERD. And that brings us to the last potential mechanism for PPI refractory heartburn, which is functional heartburn. Now, these patients don't have GERD by endoscopy and pH monitoring. They don't have histopathologic mucosal abnormalities. They don't have motility disorders. They don't have significant association between reflux episodes and heartburn by impedance pH monitoring. And they don't respond to anti-reflux treatments. And this is the group you really don't want to send for anti-reflux surgery. Now, medical anti-reflux therapy is aimed almost exclusively at gastric acid reduction. But surgery creates a barrier to the reflux of all gastric material, acidic and non-acidic. So it should relieve any PPI refractory symptom that is reflux related. But in practice, anti-reflux surgery often is ineffective for this PPI refractory GERD. And I think primarily because physicians often fail to perform adequate pre-op workup to document that this so-called GERD symptoms are in fact reflux-related symptoms. Now, here's a recent study that compared medical and surgical treatments for patients with PPI refractory heartburn. So patients who were referred to GI clinic for heartburn that was refractory to PPIs had initial symptom scoring using this GERD health-related quality of life instrument that focuses primarily on the symptom of heartburn. And if this documented that the patient in fact had bothersome heartburn, they were given a 2-week trial of twice daily omeprazole, regardless of what PPI they already were taking. But here they were given explicit instructions on how to take the drug properly, which is 30 to 60 minutes before breakfast and 30 minutes before dinner. Now, the symptom scoring was repeated, and if bothersome heartburn persisted after the trial, patients had endoscopy with esophageal biopsy and manometry. If there wasn't esophagitis or any major motility disorder, we did esophageal impedance pH monitoring while the patient was on omeprazole twice daily. And if that showed a positive symptom association probability and or abnormal acid reflux, then the patients got randomized to surgery, active medical therapy, or to placebo medical therapy. They came back for quarterly visits and for a yearly visit. Now, the surgical treatment in this study was laparoscopic Nissen fundoplication, which is widely regarded by surgeons as the gold standard anti-reflux operation. For medical treatment, all patients in both the active and placebo groups received active omeprazole twice daily. Baclofen, or its placebo, was gradually increased to a dose of 20 TID, and patients unable to tolerate or unimproved on baclofen, we proceeded to use disipramine unless it was contraindicated, in which case patient was deemed a medical failure. And if not contraindicated, disipramine or placebo was gradually increased to a dose of 100 milligrams HS. So we enrolled 366 patients with heartburn refractory to PPIs. These are the patients you see in your practices every day. Now, a little more than 19% would not or could not complete the rigorous study protocol. Now, usually we ignore the dropouts in studies, but I think it's important to appreciate the implications of this high dropout rate. If you want to get to the bottom of PPI refractory heartburn, you have to do a rigorous workup. Many patients just aren't willing to do it. Now, almost 15% of patients were excluded for a variety of technical reasons. Now, interestingly here, almost 12% of patients, heartburn was relieved during that 2-week trial of twice daily omeprazole, given with explicit instructions on how to take the PPIs properly. Often these were patients on quadruple dose therapy for years and years, but they'd never taken the drugs properly. So in a substantial proportion, just giving them good instructions on how to take the medicine relieved the heartburn. Now, non-GERD organic disorders like eosinophilic esophagitis, any major motility disorders, relatively uncommon, only 66.3% of patients. And the largest exclusion group was the 27% with functional heartburn. So we started with 366. We ended up with only 78 patients, about a fifth of the original group, who were eligible to be randomized because they had reflux-related PPI refractory heartburn documented by esophageal impedance pH monitoring. And for that highly selected group of 78 patients, 78 out of 366, who got randomized to surgery or medicine, the differences in treatment success rates were dramatic at 1 year. The success rate for surgery was 67%, which was significantly better than active medical and placebo medical treatments. And the active medical treatment success didn't differ significantly from placebo. Now, the New England Journal of Medicine insisted we publish the results only of the intention to treat analysis, but if you look at the supplemental materials, you find the per protocol analysis in which surgery was actually successful in 90% of the patients who actually had the operation. So we concluded that GERD is not the cause of heartburn. In most patients referred to GI clinics for heartburn unresponsive to PPIs. Only about 1 in 5 of the patients had reflux-related heartburn. Furthermore, simply providing instructions on how to take BID PPIs properly is effective in a very substantial proportion of patients. It's a minority, but it's almost 12%. Simple clinical maneuver that can save patients a lot of expense and inconvenience. And reflux hypersensitivity, which has been considered a functional disorder, can respond to medical treatment. So with that randomized controlled trial as a guideline, the next time you see this patient in clinic, how should we proceed? I think first thing to do is get a careful medical history, confirm the patient really has heartburn, identify warning symptoms, dysphagia, weight loss. That would suggest the problem's a lot more serious than uncomplicated GERD. And be sure to look for extraesophageal disease, especially heart disease, with symptoms like exercise-related chest pain. Once you've done all that, you can consider a 2 to 4 week trial of PPIs taken twice daily and given with explicit instruction that patients take those PPIs 30 to 60 minutes before breakfast and 30 to 60 minutes before dinner. Now, if your patient is already taking double-dose PPIs correctly, you can skip this step. If heartburn persists, then stop the PPIs. At this point, you can consider performing pH monitoring during this period off of PPIs. This is a little bit controversial as to whether or not to do pH monitoring here. People who favor doing that argue that if you get a normal pH monitoring study off PPIs, that eliminates GERD as a diagnostic consideration. Opponents argue that even though that study can establish the presence of GERD, it doesn't establish why that patient is not responding to the PPIs. Personally, I think if it's highly unlikely that GERD's the cause of the symptoms, then I might do this test to see if we can halt the rest of the workup. At this point, we would proceed with endoscopy with biopsies, ideally after stopping PPIs for 2 to 4 weeks. If endoscopy doesn't show reflux esophagitis or eosinophilic esophagitis, then esophageal manometry is performed to identify motility abnormalities like achalasia that really can cause that symptom of heartburn. If there's no major motility disorder, then esophageal impedance pH monitoring is performed while the patient is taking twice daily PPIs. If there's persistently abnormal acid reflux, then your therapy can focus on optimizing acid suppression or maybe control reflux with an anti-reflux procedure. If there is normal acid reflux and the symptom association probability for heartburn is negative, then that patient has functional heartburn, and that might be treated with neuromodulators or cognitive behavior therapy. If the symptom association probability for heartburn is positive, in a patient with normal acid reflux, you make a diagnosis of reflux hypersensitivity. And patients with reflux hypersensitivity can be treated with anti-reflux lifestyle modifications, baclofen, alginates. Frankly, the medical maneuvers here don't work terribly well. Anti-reflux procedures like fundoplication can be recommended in highly selected patients. So, finally, when you're managing patients with Ppi refractory GERD symptoms, it often requires that you have to make some difficult decisions, and the outcomes might not be ideal no matter what. But you can be comforted by the fact that bad decisions often make for some real good stories. So thank you for your attention this morning.
Thank you very much, Dr. Speckler. I'd like to welcome our next speaker, Dr. Brian Lacey. He's a professor of medicine at the Mayo in Jacksonville by way of Dartmouth-Hitchcock, where he was section chief. He is author of so many peer-reviewed articles, Interest in Disorders of GI Motility, and a Board of Trustee member for the Rome Committee and the ACG. And of course, we appreciate his work as co-editor-in-chief of our Red Journal. Thank you very much.
Well, welcome, everybody. I'm so delighted to be here in person, and I'd like to thank our organizers and Kai Camaro. And I apologize, I'm a little underdressed. I haven't traveled in business for about 2 years. I got so excited, I left my jacket on the plane. So if you see somebody wearing a really nice blue Italian sport coat that doesn't fit them, that's probably mine. So we have a whirlwind tour here this morning. And my job is to kind of cover the pharmacologic agents we use for upper GI disorders, not focusing on GERD, because we just heard this amazing presentation by Dr. Speckler. And the ones I'm going to focus on are functional dyspepsia and gastroparesis, but also mention chronic nausea and vomiting and cyclic vomiting syndrome and cannabinoid hyperemesis syndrome. And I like to focus on functional dyspepsia and gastroparesis because they're kind of the models for these sensory motor disorders of the upper GI tract, and because they're some of the things that we focus on so much in clinical practice. My typical daily clinical schedule is everybody has refractory nausea and vomiting or IBS or constipation. And my job is similar to yours, meaning we really need to tease out and really need to put on those kind of great detective hats why people have nausea and vomiting. Dr. Speckler has already nicely mentioned the Rome criteria. We can certainly debate that. It is an evolution, like all good things in science. We're constantly evolving and learning. But right now, when we think about dyspepsia, we think about symptoms thought to represent a problem in the gastroduodenal region. And we typically break it down to meal-related symptoms, postprandial distress, or epigastric pain, which only has to be present 1 day per week. How do we treat functional dyspepsia? And this is, I know you all have slides and handouts available to you, so some of these will just be briefly mentioned. But this is kind of our armamentarium right now. And I think it's nice that we have different choices for different patients, and we really need to individualize treatment. I'm only going to briefly mention the word H2 blockers because the meta-analysis from 20 years ago was significantly flawed. They don't work for functional dyspepsia. Move on. What about PPIs? We've learned that PPIs are great drugs for esophagitis, right? These are amazing drugs for esophagitis, not so good for some of the other symptoms of reflux, and only okay for functional dyspepsia, meaning that if you have somebody who meets Rome 4 criteria, you need to treat 14 in a row to have one patient respond. We just heard this great lecture about Ppi non-responders. This is one of those patient groups we need to think about. By the way, the teaching point here is a twice daily PPI for functional dyspepsia is no better than a once daily PPI, and certainly 4 times is not any better at all. Okay, what about tricyclic? So Dr. Speckler already kind of set the stage. Thank you very much. And we need to think about these things called neuromodulators. And when I talk about lower GI pharmacology, I'm going to go through them a little bit more carefully. But for the upper GI tract, we'd like to think about tricyclic antidepressants. By the way, in clinical practice, don't use that phrase. Say, Mrs. Jones, you have chronic pain. We're going to talk about modulating the nervous system. We're going to use a neuromodulator. Now, you know they're going to look them up anyways, but remind them that you're not treating them for depression, you're treating them for pain. And the doses we use are much lower than for depression. And these agents, which have a 50-year track record of success, can be very effective. I like to point out that there are tertiary amines, imipramine and amitriptyline, and secondary tricyclics, and they differ in terms of side effects. Low doses typically don't cause a lot of side effects as you move the dose up. Yes, they can cause dry mouth, dry eyes, and even constipation, but not low doses. This next slide illustrates why the tertiary amines amitriptyline and imipramine are more likely to have a side effect because they have more antihistaminic and more anticholinergic side effects. So if somebody is very sensitive to medications, you may want to start with a secondary tricyclic such as disipramine. I start at low doses, 5 to 10 milligrams at night, an hour before bedtime, and slowly escalate. Most patients need in the 30 to 50 milligram range. We didn't have much data until this great study published by Nick Talley and colleagues in gastroenterology now 6 years ago. This is a North American study, 8 large treatment programs throughout both Canada and the United States, comparing a tricyclic to an SSRI to a placebo. And what was found is that a tricyclic for functional dyspepsia, and these patients were rigorously scrutinized. It took 5 years to get 282 patients in this study. And we found that patients with ulcer-like dyspepsia, that pain, pressure, fullness, were much more likely to respond than patients who did not have those symptoms. And those with delayed gastric emptying were less likely to respond. By the way, that mimics the Norrig trial by Henry Parkman, showing that idiopathic gastroparesis patients don't have a great response to tricyclics. A key teaching point, though, is low-dose tricyclics do not slow gastric emptying. What about prokinetics? Remember that about 25% of functional dyspepsia patients have a mild delay in gastric emptying. Mild is the key word here. Could you thus use a prokinetic agent, whether tegaserod or cisapride or idapride or prucalopride, to improve dyspeptic symptoms? And we published a study a couple of years ago in the Red Journal showing that, yes, you can, but if you look at the data and look at that kind of line drawn in the sand, If you looked at that line drawn in the sand, you realize that it's just slightly better than placebo. Not perfect, but slightly better than placebo. Let's think about some atypical agents. Remember that about 40% of your patients with dyspepsia have problems with gastric accommodation. They feel overly full, overly stuffed. Just like I ate Thanksgiving supper, but I only ate a small meal. That's because gastric accommodation is impaired, and this involves mechanoreceptors or tension receptors in the fundus. Could we improve that? Absolutely. So buspirone, Buspar, a mild anxiolytic, acts on the 5-HT1 receptors in the fundus and improves fundic accommodation. Does this work? We have a nice study from Jan Tak and colleagues published in the Blue Journal, CGH, a few years ago, showing that buspirone here, shown in green, compared to placebo, shown in red, improved meal-related dyspeptic symptoms. So your patient with FD and postprandial distress syndrome, don't be afraid to use Buspar. I start at 5 milligrams before meals and slowly escalate. By the time patients reach about 20 TID, they may have some fatigue, and that's usually the dose limiting effect. Mirtazapine. As you become more comfortable with these agents, think about using mirtazapine. And mirtazapine, in my opinion, this atypical antidepressant is kind of a dirty drug, but a dirty drug for dyspeptic symptoms is great because we have so many different neurotransmitters and sensory pathways involved. And what I mean by a dirty drug, it acts on serotonin receptors, it acts on histamine receptors, it acts on noradrenaline and alpha-2 agonist receptors as well, and those are all involved in pain pathways. And we know that Remeron, mirtazapine, can improve appetite and nausea and dyspeptic symptoms. What's the data? Again, a great study from Jan Tak and colleagues published in CGH 5 years ago, showing that in a small group of patients, these are very difficult studies to perform, and this double-blind 8-week study that mirtazapine Remeron used once daily improved dyspeptic symptoms. I tend to start at 7.5 milligrams an hour before bedtime. A week to 10 days later, go to 15. Most patients need about 30 milligrams. Patients will feel a little sedated early on, but that tends to go away. At higher doses, some people get a little constipated. Let them know about that. What about virtual reality? So we have some really neat data showing that virtual reality can improve pain for burn victims and IV placement in kids and severe trauma accidents. We're doing a really neat study. You're going to see this at ACG in 2021. Dr. Greenwald is well aware of that. And you're going to see neat data that functional dyspepsia is attacking this brain-gut axis and dramatically improving FD symptoms. You can have your patients do this at home. Many of us were taught that you either had functional dyspepsia or you had gastroparesis. They're completely different disorders and never the twain shall meet. That is completely wrong, and we've been arguing that for years. And what I want you to walk away with today is that these two disorders are very, very similar. And I want you to start thinking about dyspepsia with either accelerated emptying. And by the way, I will challenge you, patients with rapid emptying, with dyspepsia or chronic nausea and vomiting, you can't distinguish that from somebody with slow emptying and nausea and vomiting. Most patients have normal emptying with dyspepsia, 7% have rapid, and only about 20-25% have a mild delay. And this has been proven now by this very nice study from Jay Pashrisha and colleagues from the NIH Gastroparesis Consortium, looking at nearly 1,000 patients over 12 years, showing that at the end of 1 year, 42% of patients initially classified as gastroparesis now met definition for functional dyspepsia because their gastric emptying scans were normal. Conversely, some people initially identified as functional dyspepsia now had gastroparesis. By the way, the teaching point is most gastric emptying scans are done incorrectly. We just published a study looking at 800 centers. Only 5% did them absolutely correctly. It's embarrassing. Make sure it's a 4-hour scan and solid phase. So then if you identify somebody with gastroparesis, how do you treat them? Again, this is in your handouts and slides, kind of an algorithmic approach from simple to more complicated. What about using a prokinetic? So we know the definition of gastroparesis is delayed gastric emptying in the absence of mechanical obstruction with a documented delay using a 4-hour scan. Could you use a prokinetic? And we have multiple prokinetics available. Are they effective as a group? Yes, to some degree. But remember, although this statement is controversial to some, accelerating gastric emptying will not improve all of your symptoms of gastroparesis. It usually will not help nausea. It won't help pain, present in 90%, and may only marginally improve vomiting. So we use them, but they are not great drugs as a class, and we need to be more creative. Metoclopramide has now been around for over 40 years. In New Hampshire, we were not allowed to have billboards along the highways. So this green state is very pretty. When I drove down to take my job at Mayo in Jacksonville and drove into Florida, the first billboard I saw was, "If you took metoclopramide, sue your doctor." And I thought, well, welcome to Florida, right? This is just great. So metoclopramide has been around a long time. It is the only drug approved by the FDA for gastroparesis. So if you stick to the rules, the only medication you should be giving is metoclopramide. And we know that at low dose, it's a reasonable antiemetic and a mild prokinetic, and it can help. Here is really the world's data supporting the metoclopramide for the treatment of gastroparesis. 8 studies, short, small number of patients, different outcomes. Some are even open labels. So we don't have great data. That said, I think it's a reasonable treatment option. If you follow guidelines, it's really theoretically the only thing you should be using. We do know that some people have side effects. About 30% of diabetics will have a mild side effect of a little anxiety, a little bit of skin twitching, a little bit of sleep disorders, and some mild gynecomastia. As you may know, there's now a nasal form. This was approved in 2021 for metoclopramide. It should be given 4 times daily. Interestingly, if you looked at this double-blind phase 2b study, there is no difference between drug and placebo. But if you teased out the men, it did seem to improve symptoms more in women than in men, which is why it was approved. It's a treatment option, especially for some people with refractory nausea and vomiting where they can't get pills down. You can also use sub-Q, as you know. We'd already mentioned side effects. The biggest concern, of course, is tardive dyskinesia, but that's way overstated. The likelihood is probably less than 1%. What rules should you follow in clinic? No more than 12 weeks. Keep the dose less than 40 milligrams per day total, and don't use in women over the age of 70. Most likely have side effects. What about domperidone? If I had to choose a prokinetic for gastroparesis or even functional dyspepsia, domperidone is the one I would use. It's a very good antiemetic. It's a reasonable prokinetic. It has very poor penetration of the blood-brain barrier, and side effects are much lower. The problem, of course, is that it's not approved, and you need to get a special IND. This is the data supporting the use of domperidone for gastroparesis. Again, I think it's a reasonable option. You can help your patients get it by filing an IND in your site. Some patients go to Canada, not unreasonable. I'm only going to briefly mention a few other cholinergic agents because some providers and some patients still use this. Bethanechol is a direct-acting parasympathomimetic. It does improve smooth muscle contractions. Some patients with gastroparesis or dyspepsia find benefit. In my practice, at least, I tend to use it more for patients with persistent reflux symptoms and documented significant ineffective esophageal motility. There's a little bit of data supporting that's use, and I think it can help. Don't forget, as you push the dose, because it is a parasympathomimetic, it's going to cause cramps and spasms and urgency. So be careful. Similarly, you can use pyridostigmine. This drug has been around for about 60 years now. It's an acetylcholinesterase inhibitor. And there's really no data for dyspepsia or gastroparesis, although used off-label by many tertiary care centers. Again, it improves gastric motility and small bowel and colonic motility as well. We do have an interesting study looking at diabetics who had overlapping gastroparesis and constipation, showing it seemed to improve some of their symptoms. Start at a low dose, 30 milligrams once a day, increase using a liquid form to 30 TID or 60 TID. Macrolide. So if we had to choose the best gastrokinetic, the most potent gastrokinetic shown to accelerate and or normalize gastric emptying, you would choose erythromycin. It's a motilin agonist. Again, it's been around for over 60 years. And this stimulates the MMC, stimulates antral contractions, and improves gastric emptying. But remember, I've already mentioned improving gastric emptying does not equate with improving gastroparesis symptoms. I tend not to use it in my practice because of that. In addition, there's rapid tachyphylaxis. The motilin receptor downregulates, and so any benefits will occur in the first week or so, and then they just wear off. Could you use prucalopride? So prucalopride is a 5-HT4 agonist that acts on the serotonin system. We know there are several great studies showing it improves chronic constipation. Could you use it for gastroparesis? The answer is yes. And this double-blind crossover study from Jan Tak and colleagues, once again from Leuven, Belgium, over 4 weeks, it did improve gastroparesis symptoms here using the GCSI on the left-hand side, the Gastroparesis Cardinal Symptom Index, and also with patient-reported scores on the right-hand side, the PAGI quality of life. We don't have long-term data. Nausea and vomiting. So think about antiemetic therapies. Unfortunately, we have a host of agents, and I think the idea would be to become comfortable with one agent in each class and kind of get to know one agent in each class so that you're aware of both positive benefits and negative side effects. I'm not going to go through all of these in the interest of time. I want to highlight granisetron. By the way, of course, not FDA approved because only metoclopramide is for gastroparesis. But for many patients with persistent nausea and vomiting who have trouble getting pills down, a patch can be helpful. And there is data in gastroparesis patients showing that it can improve symptoms of nausea and vomiting. Don't forget, because it's a 5-HT3 antagonist, it slows things through the GI tract, and some people can become constipated. In addition, don't forget a plain old-fashioned scopolamine patch. Cheap, easy, simple, safe, and it helps. The pathways of nausea and vomiting are incredibly complex. Multiple pathways, multiple neurotransmitters, and NK1 receptors are intimately involved. Could we block those receptors and improve symptoms of nausea and vomiting? Absolutely. And many of your anesthesia colleagues do this all the time to help with post-operative nausea and vomiting. A number of forms available, aprepitant, tradipitant, rolapitant. Let's focus on aprepitant first. This is again an NK1 antagonist. This was a really nice study published in Gastro about 3 years ago. It focused on patients with gastroparesis or symptoms thought to represent gastroparesis, chronic nausea and vomiting. And that's important because not all these patients had gastroparesis. 4-week study, patients randomized to aprepitant or placebo. The primary outcome was not met using a visual analog scale. Nausea did not improve. But if you looked at secondary outcomes using the Gastroparesis Cardinal Symptom Index, there was a benefit for aprepitant. So this, again, is an option, sometimes difficult to obtain through insurance companies due to the cost. This was followed by another study looking at tradipitant, and this study was positive, again, a 4-week study, and was positive, at least in my mind, because they focused only on gastroparesis patients and those with more severe to moderate nausea. And in this study, looking at 85 milligrams daily compared to placebo, the primary outcome and improvement of nausea was met, as were multiple secondary outcomes. So put this in your armamentarium as well, and K1 antagonists. Could you use mirtazapine? We briefly mentioned this atypical antidepressant as well. We mentioned how it can improve symptoms of nausea and vomiting, and the answer is yes. By taking it at night at 15 milligrams, you may improve some of these symptoms of nausea and vomiting, and probably this low dose will not dramatically worsen gastric emptying. I briefly want to mention Ghrelin Agonists. So this is a 28 amino acid peptide. It acts as a gastrokinetic, and in animal studies and phase 1 human studies, it does accelerate gastric emptying to a slight degree. Lots of enthusiasm about this. 2 nice articles in Gastroenterology, but all trials have been stopped. Why? Not for safety, but basically it really doesn't work. We'll move on. Lastly, in the last 37 seconds, belching. We already mentioned from Dr. Speckler that baclofen as a GABA agonist may improve symptoms. Most of this is gulping air. Behavioral therapy can be helpful. Cyclic vomiting syndrome, it's not just a disorder of children and adolescents, but it can occur in adults. When you think about cyclic vomiting, you need 2 courses of therapy. You need an acute rescue plan, antiemetics, sublingual ondansetron, maybe a Phenergan suppository, a benzodiazepine, it's okay to do that, and maybe a smooth muscle spasmodic, and you need chronic therapy, and typically tricyclics. Cannabinoid hyperemesis syndrome, we're all aware of it. Don't forget to ask the question, if in doubt, check a urine tox screen. And chronic nausea and vomiting is basically treated like gastroparesis. Okay, I'm going to stop there in the interest of time. Thank you for allowing me to speak today. We got a lot of information, but fortunately, a lot of this information we briefly went through is in your slides and handouts. Thanks.
Thank you, Dr. Lacey. That was excellent. We're going to welcome Dr. Speckler back up to the podium for esophageal motility, new perspectives.
Okay, well, thank you again. All right, now this is often a room-clearing event talking about motility, but I'm going to try to make this less complicated. It really is not complicated. People try to confuse this. It's really simple. Let's start with some basics regarding high-resolution manometry. So a typical high-resolution manometry catheter has 36 solid-state pressure sensors. They're spaced at 1 centimeter intervals. The data that's recorded by these sensors gets processed using computer algorithms, and then it's displayed in color-coded pressure topography graphs. Now, in high-resolution manometry, we said esophageal pressure is color-coded, so that the redder something is, the higher the pressure, the bluer it is, the lower the pressure. So on this normal tracing, you see that a swallow results in an abrupt collapse of pressure in the upper esophageal sphincter, which is shown by that sudden color change from yellow to blue. And that's followed by a normal peristaltic increase in pressure, and it's shaped like a hockey stick. Now, to interpret these studies, you need to determine only a few key measurements. So first, let's focus on what's happening at the EGJ, the esophagogastric junction, during that 10-second interval after the swallow. That's called the deglutative EGJ relaxation window. Now, during that relaxation window, the computer can determine the integrated relaxation pressure, the IRP, which is essentially LES relaxation with swallowing. Now, IRP is the lowest mean relaxation pressure for a 4-second period in the deglutative relaxation window. And with the most popular recording systems, we say that it's abnormal, impaired EGJ relaxation, when the IRP is 15 millimeters of mercury or higher. Now, it does vary by manufacturer, so if you're not using one of the more popular systems, check what your upper limit of normal. Because the upper limit of normal of IRP is a major branch point in how you interpret these high-resolution manometry studies. Another key measurement is the so-called distal contractile integral, or DCI for short. Now, by convention, high-resolution manometry computer gives you this two-dimensional display of esophageal motility, like this. But you could also ask the computer to display it in 3 dimensions. And when you display that swallow in 3 dimensions, it looks something like a mountain range. And the volume of that mountain range structure is an indication of the force of esophageal contraction. And remember that if you want to calculate volume of something, the formula is some permutation of height times length times width. So if you have a 3-dimensional display like this, length is height is the pressure in millimeters of mercury. Length is the length along the esophagus in centimeters from the pharynx. And the width is time in seconds. And the computer will compute the volume of this complex mountain range structure, and that volume is called the distal contractile integral. And in this case, the distal contractile interval is more than 11,000, and the units reflect the volume measurement as millimeters of mercury times centimeters times seconds. And a normal DCI is greater than 450 and less than 8,000. And the last key measurement that you need to interpret motility is the distal latency. So to measure the distal latency, you first locate the start of the swallow, and then you locate the contractile deceleration point. And that's the point where there's this sudden sharp bend in the hockey stick of the peristaltic wave. And the distal latency is the time from the start of the swallow to the contractile deceleration point, and a normal distal latency is more than 4.5 seconds. Okay, those are basically all you need to interpret these studies. Now, this slide shows the Chicago classification version 3 that just this year was replaced by version 4. Now, for version 3, all swallows were performed with the patient supine, and then we would recognize motility disorders, as I'll show you here. So again, I said the IRP is a key branch branch point. If the IRP, LES relaxation, essentially, if the IRP is the limit of normal and there's no peristalsis, then that patient had achalasia. If there's any peristalsis preserved and the IRP is elevated, we didn't call that condition achalasia, we called it Egj outflow obstruction. Now, if the IRP is normal and the distal latency was less than 4.5 seconds in 20% or more of swallows, then that diagnosis was distal spasm. If the DCI, the force of contraction, if that was greater than 8,000 in 20% or more swallows, then the diagnosis was jackhammer esophagus. And if there was 100% failed peristalsis, we would diagnose absent contractility. And then there were two minor disorders of peristalsis. If the IRP was normal and the DCI was less than 450 in 50% or more of swallows, the diagnosis was ineffective motility. And if those swallows were fragmented, we called it fragmented peristalsis. So what has changed? That's the old classification. What's changed with Chicago classification 4.0? Well, for one, the standardized manometric protocol now includes swallows performed in both the supine and in the upright positions. In addition, the standardized protocol now calls for multiple rapid swallows. We'll talk about them in a moment. And the protocol also calls for what's called a rapid drink challenge. And version 4 doesn't distinguish between major and minor disorders of peristalsis. Now, by the old version 3, if the IRP is above the upper limit of normal and there's no peristalsis, then you'd make a diagnosis of achalasia. We had these different subtypes. But if any peristalsis was preserved and the IRP was above the upper limit of normal, then we call this Egj outflow obstruction. And this is the one condition for which there are major changes now between version 3 and version 4. Now, Egj outflow obstruction has caused a lot of confusion, in part because there are so many causes of this manometric abnormality. In many cases, Egj outflow obstruction is an achalasia variant, but it can also result from any process that infiltrates the wall of the esophagus, like eosinophilic esophagitis or an infiltrative cancer. Both of those can interfere with LES relaxation. Alternatively, anything that pushes on the wall of the esophagus, like extrinsic vasculature or a big paraesophageal hernia or abdominal fat, those can also elevate the IRP. Opiates clearly elevate the IRP. Be careful when you interpret studies in patients on opiates. But a lot of times, Egj outflow is just a spurious finding and has no clinical importance whatsoever. Now, here's a study showing that upright IRP, this is why we now do the studies in both the upright and supine posture, because upright IRP can distinguish important from unimportant Egj outflow obstruction. So in this study, the researchers took 10 supine swallows, in which the upper limit of normal was 15, and they also got 5 upright swallows, for which the upper limit of normal is 12. And they found that an upright IRP of greater than 12 identified patients who had radiographic evidence of a real disorder with 98% sensitivity and 16% specificity. For example, in panel A, this patient had an elevated supine IRP of 21, but when they sat the patient up, the upright IRP fell below 12, and this patient had a normal time barium swallow and normal passage of a barium tablet. Now in patient B, he had elevated supine and upright IRPs, and a barium tablet got held up at the EG junction. And similarly in panel C, that patient had elevated supine and upright IRPs, and the time barium swallow showed an elevated barium column at 5 minutes. So again, that's how you would use the upright IRP. Now let's examine a normal swallow one more time and notice what we don't see during this period of deglutative EGJ relaxation. We don't see this intrabolus pressurization. Now, we don't see that abnormal rise in pressure within the bolus because the EG junction has relaxed. But if it didn't relax with swallowing, as it does, for example, in achalasia, and now you have peristaltic wave pushing from above, okay, which wouldn't occur in achalasia, but if you have EGJ outflow obstruction and something's pushing from above, then you see this rise in intrabolus pressure. And it's a rise in that compartment between the peristaltic contraction proximally and the closed EGJ distally. So here are the features of Chicago 4 for diagnosing outflow obstruction. This diagnosis now requires an IRP greater than the upper limit of normal in both supine and upright positions. There has to be some preserved peristalsis, and at least 20% of swallows have to show that increased intrabolus pressure. Furthermore, this manometric diagnosis is always considered clinically inconclusive. In other words, you have to distinguish a clinically relevant outflow obstruction, meaning a pathologic disorder that's going to respond to treatment, from a clinically irrelevant manometric curiosity. And a clinically relevant diagnosis of outflow obstruction requires symptoms of dysphagia or chest pain, and you have to have some test that shows you there really is an outflow obstruction. And that test can either be an abnormal time barium swallow or functional luminal imaging probe, FLIP for short. So let's take a moment to talk about FLIP. Let me just ask, how many of you have this available in your clinical practices? Okay, Brian, you do? And not too many. That's fine. You don't need it. Okay, you really don't. It's an impedance, but you should know how it works. Okay, okay. It's an impedance planimetry technique. Impedance planimetry uses measurements of voltage between electrodes in a fluid-filled balloon, and that uses that to estimate the cross-sectional area, the CSA, of a segment of the esophagus. So that FLIP catheter gets passed through the mouth into the stomach. At the end of the catheter, you have this cylindrical balloon that can be filled up gradually with saline. And within the balloon, there's 16 paired impedance electrodes. And also within the balloon, you have this little pressure sensor. And the outermost electrodes are connected to a low voltage current source. So in this system, the electrical current, the conductivity of that saline solution, and the distance between those electrodes, we know all of those. Those are constants. They're known constants. And with those constants, your measurement of voltage, now you measure voltage between the electrodes, and the computer uses Ohm's law to determine impedance, electrical resistance, and that electrical resistance is proportional to the cross-sectional area of the balloon between the electrodes. These cross-sectional area measurements, they're easily converted into diameters, and the computer uses those to construct this three-dimensional image of the esophagus, and it displays that to you in real time. In this example, in which the balloon is filled with 60 millimeters of saline, each individual ring here represents the diameter at that electrode pair, and at the EGJ junction, the diameter is 15.4 millimeters. And the computer also gives you this pressure reading in the balloon. So how are you going to use this? Well, it can provide useful information about how distensible any area of the esophagus happens to be. And you can determine this distensibility index by dividing the narrowest cross-sectional area in that segment you're interested in, which is usually the EG junction, and you divide that by the pressure within the FLIP balloon. So for example, in this left panel, when 50 millimeters of saline was pumped into that FLIP balloon of this healthy subject, it distended the EG junction to a cross-sectional area of 184. It generated an intra-balloon pressure of 42 millimeters of mercury. And so if you divide the cross-sectional area by the intra-balloon pressure, you get a distensibility index of 4.4. Now, in contrast, in this achalasia patient on the right, when you put in that same 50 milliliters of saline, now you get a cross-sectional area of only 49. And you generate a higher pressure, right? You have a squeeze at the EG junction so it doesn't open up, and now the balloon pressure goes up because that EG junction doesn't go up. And now you get a really low EGJ-DI, Distensibility Index of 0.8. Recent studies established that the mean normal EGJ Distensibility Index is 5.8, and anything below 2.8 is abnormal. This group has recently lowered the standard. It's less than 2 we consider abnormal. This is a group that changes the standards from week to week, so we'll see what next week says. Now, rapid drink challenge. So this is also part of the standard protocol. It can support a diagnosis of outflow obstruction. For rapid drink challenge, you have the patient drink 200 milliliters of water as fast as they can through a straw. And remember that when you swallow, swallowing causes inhibition in the body of the esophagus, and it also inhibits the lower esophageal sphincter, right? So they're getting inhibition during swallowing. So while this healthy control subject swallows rapidly, there's absent esophageal body contractility and complete relaxation of the LES, and the IRP during that period falls to almost 0. Now, in contrast, here's a patient with EGJ outflow obstruction. Now, when that patient starts swallowing, the IRP doesn't relax, right? The LES doesn't relax. It remains above 12 for the first 30 seconds, and pressure in the esophagus rises as it fills up with fluid, reflected by this panesophageal pressurization. Now, the other disorder for which there have been major changes between version 3 and version 4 is ineffective esophageal motility, or IEM. And my late friend and mentor, Don Castell, figures very prominently in the history of this ineffective esophageal motility. So in 1987, Joel Richter, who was working with Don at the time, used conventional manometry. He showed that peristaltic contractions with amplitudes less than 30 millimeters of mercury were ineffective for clearing a radionuclide liquid bolus from the esophagus. The next year, Peter Karillis confirmed that 30 millimeters of mercury was indeed the minimal peristaltic amplitude that you needed to clear barium out of the esophagus. In 1997, Castell's group coined the term ineffective esophageal motility. Now, back in 97, any manometric abnormality that didn't meet criteria for a named motility disorder was called a nonspecific esophageal motility disorder. But these investigators found that almost all of these cases they called nonspecific esophageal motility disorders had at least 30% of swallows with failed or absent peristalsis, or with peristaltic contractions that were very low amplitude. And in 2001, Don and I included this IEM in the conventional manometry classification of esophageal motility disorders. In 2008, Castell's group revised the criteria for at least 30% to at least 50% ineffective swallows. In 2012, the Northwestern group said that the high-resolution manometry correlate of that 30 millimeter ineffective conventional swallow is one with a DCI less than 450. In 2015, ineffective esophageal motility got incorporated into the Chicago classification version 3. And just this year, IEM criteria were again revised in version 4, includes a normal IRP with more than 70% ineffective swallows, or a normal IRP with at least 50% totally failed swallows. So the reason for this long discussion on this thing is when you compare studies on IEM, you have to appreciate how much the diagnostic criteria have changed since 1997 when that condition was first described. So IEM diagnostic criteria have changed considerably over the past 20 years. You can find this condition in healthy, asymptomatic individuals, but you can also find it in the patients with dysphagia and in patients with GERD, and patients with GERD might get treated surgically, but preoperative ineffective esophageal motility does not reliably predict who's going to get dysphagia after an anti-reflux procedure. And IEM can improve, worsen, or even appear after anti-reflux surgery. So IEM, it's really kind of a garbage diagnosis. It's of unclear importance. There's no effective treatment for it anyway, so even if you find it, you can't do much about it. Okay, so much ado about nothing, I think, with IEM. Here are the abnormalities that contribute to this diagnosis of IEM. A swallow can be followed by no activity in the body of the esophagus. We call that failed peristalsis, and DCI here is considerably less than 100. Or a swallow can be followed by weak peristalsis with a DCI between 100 and 450, or a swallow can be followed by fragmented peristalsis, which has a normal DCI, but it has breaks in the peristaltic contour. By Chicago classification version 4, the definition of IEM is a lot more stringent than it was in 3. It includes fragmented peristalsis. Now, the diagnosis requires more than 70% ineffective swallows, and those include weak contractions, failed peristalsis, and fragmented peristalsis. Or you can have 50% failed peristalsis. Now, surgeons worry about causing dysphagia with their anti-reflux procedures if your pre-op motility study shows IEM. And this is where this multiple rapid swallow test can help. In this test, the patient swallows 5 2 ml wet swallows administered 2 to 3 seconds apart. Now, during those rapid swallows, there's absent contractility and complete LES inhibition. But this period of inhibition normally is followed by an esophageal contraction that's more powerful than just with a single swallow. So if the post multiple rapid swallow DCI is greater than the single swallow mean DCI, that means the patient has a contraction reserve. And lack of contraction reserve supports this diagnosis of IEM and might make it important, whereas a contraction reserve in patients with weak peristalsis suggests that if you do a fundoplication, it's not likely to result in dysphagia. So here in a nutshell is Chicago classification version 4. If the IRP is above the upper limit of normal and there's no peristalsis, that patient has achalasia. If there's some peristalsis preserved, we call it Egj outflow obstruction. If the IRP is normal and the distal latency is less than 4.5 seconds in 20% or more swallows, that's distal esophageal spasm. If the DCI is greater than 8,000 and 20% or more swallows, we call that hypercontractile esophagus rather than just jackhammer, which was the old term. And if there's 100% failed peristalsis, the diagnosis is still absent contractility. If there's weak contractions, failed peristalsis, or fragmented swallows in more than 70% of swallows, or more than 50% failed peristaltic sequences, then we call it ineffective esophageal motility. And for all those disorders that I put an asterisk next to them, like Egj outflow obstruction, distal spasm, and hypercontractile esophagus, by Chicago version 4, the patient must have symptoms for the condition to be considered clinically relevant. And that's motility in a nutshell, and I hope you didn't find it too hard to swallow. So thank you.
Thanks, Dr. Speckler. That was great and actually made it a lot more accessible for most of us. So next we're going to hear from Prashant Kadia. So he came to Dallas by way of New York, both Mount Sinai for his GI and then Weill Cornell for his advanced endoscopy fellowship. He's also a former course director for the TSGE, which we really appreciate. Currently, he is the medical director of advanced or interventional endoscopy for Methodist Dallas Medical Center. And he's going to be speaking about poeming in the 2021. What is at the end of the tunnel?
Thanks, Lisa, and the TSGE board for inviting me to speak today and for being on this esteemed panel of speakers. We just got two very cerebral and physiologic-based lectures from thought leaders in our field, and I feel a little bit out of place. I'm like the young guy coming in and say, cut everybody now. So hopefully I'll try to be as insightful as our previous speakers here, but we'll be talking about poeming in 2021, what's at the end of the tunnel. So you probably hear these terms now when you're going through some journals and stuff, all these new terms, poem, ESD, STIR, EFTR. What are they? What do they all mean? They're all terms in this mixed bag of this new field called third space endoscopy. But what is that? Let's define what third space endoscopy is. So the first space, when we're doing endoscopy, that's the lumen. That's where GIs like to live, inside the lumen of the GI tract. And the second space is the peritoneum. This is where surgeons like to live, and we like to keep our worlds separate. The third space now is this new area that we've started to work in. It's called the intramural submucosa. So as you know, the GI tract is lined with multiple layers, the mucosa, submucosa, muscle layers, and the serosa, and that submucosal layer is made up some wispy connective tissue with vascular structures and whatnot. But a lot of us work in that space frequently. So when you're doing an EMR, and you're trying to raise a polyp by injection, you're essentially injecting the submucosal space and causing that space to expand because of its expandability with fluid. And so this is not a foreign space, it's just that we're utilizing it differently going forward. But what led us here, what led us to this field, is really born out of this concept of notes, which, a decade or two ago was picking up speed in terms of exiting the first space, the lumen of the GI tract, to go into the second space, the peritoneum, and take out organs like appendices and gallbladders and then come back in. But to do that, the goal was to leave the first space and enter the second space so that you could do work but not cause contamination. So GI surgeons at that time were conceptualizing ways to do this. And what they thought was a safe way to potentially leave one space to the other was to do this submucosal tunneling, where they would inject the submucosa and enter a space with the endoscope between the mucosa and the muscular layers and tunnel along that space and then exit the muscle into the peritoneum. And then you do your surgical work, and when you came outward to retract the endoscope, you would have a mucosal flap over that perforation that would seal that space and prevent contamination. But lo and behold, doing that submucosal tunneling led to this whole world of third space endoscopy, which really is what we're going to be talking about today, is POEM. So what is POEM? Per-oral, by mouth, endoscopic, and myotomy, cutting of muscle. And so all of the POEM procedures we talk about today are variations of this. So the first POEM was actually performed in 2008 by a Japanese surgeon named Haru Inoue, who was a cardiothoracic surgeon, but also an endoscopist. And he has become really a living legend now in our world today because since his procedure back then, it's caught on like wildfire. But since then, POEM is now being performed in all parts of the upper GI tract for various different indications, and it's evolved over time. We're not going to be able to talk about all of them today, but we'll talk about a few of them for achalasia, Zenker's, diverticulum, and gastroparesis. So we just had fantastic lectures on motility and achalasia. So as you know, this is a motility disorder of the esophagus. The sine qua non pathologic features, incomplete relaxation of the lower esophageal sphincter, the IRP, which Dr. Speckler talked about. And there's 3 different flavors of achalasia depending on the proximal dysmotility pattern. But all of them do produce similar symptoms in terms of this Eckhart score of dysphagia, regurgitation, chest pain, weight loss, and you'll classically get this bird's beaking pattern for type 1 and type 2 achalasia on the barium esophagram. The treatment, the gold standard treatment for achalasia is a myotomy, an LES myotomy. Conventionally in the past was only be able to perform via surgery, known as the Heller myotomy procedure, but the POEM procedure really changed this and gave a new minimally invasive option, which Haru Inoue kind of conceptualized. The POEM has now been being performed now, thousands of cases around the world, and it's evolving, but the steps of it have remained constant. And the steps are 4 here. One is a mucosotomy, meaning that you use a scope to penetrate the mucosa and enter the submucosal space. The second step is submucosal tunneling, where you tunnel the scope down through that submucosa all the way across the LES into the proximal gastric cardia. And then the third step is a myotomy. This is really the therapeutic part of the procedure where you're cutting the muscle, especially the LES, hypercontractile LES complex there. And then the last step is closure, closing your mucosotomy to prevent contamination of the first space into any of that second space. Here's a video of how we actually perform this. This is an anterior POEM, so we actually are doing more posterior, but this is just an older video here. But here we're using a needle to inject that submucosal space. We will always use some methylene blue in our injectant just to kind of dye the submucosa and helps guide our pathway. We're using an Irby hybrid knife here that allows for us to do injection, cutting, and coagulation. So now we've entered this tunnel, and these wispy fibers here are the submucosal fibers. You can see they're just kind of connective tissue. They have blood vessels inside of them, so this knife will allow you to coagulate blood vessels and then also cut the fibers. So as you've tunneled down this space now, and here we're going all the way down to the end of the tunnel that we've created, you can see that you've crossed the LES, and then you actually enter into the gastric cardia side. And then once you've done that, it's usually about a 12 to 13 centimeter tunnel at least, you can start your myotomy. So here at the end of the tunnel, we always want to confirm that we've crossed over to the gastric cardia side. So one thing we'll do is retroflex in the stomach itself, and you'll see that submucosal bleb there, that bluish colored bleb that confirms that we've gone at least 2 or 3 centimeters into the gastric cardia. Then we can enter back into the tunnel and we can start the myotomy. We start from proximal to a distal myotomy. And as you know, the esophagus is surrounded by circular and longitudinal muscle. Some centers will just do a circular myotomy. Some centers will do a full thickness myotomy. But you can use various different knives to do this myotomy. And in general, you're doing at least a 12 to 13 centimeter myotomy. And here you can see the length of the full thickness cut across the LES. And this is peritoneum that you're seeing on the other side. But we also use this thing called holy water, which is just gentamicin wash. I don't know if it actually does anything, but we all use it to kind of clean the tunnel here. And then we close the POEM with some clips or suturing or whatnot. So those are really the basic steps for POEM. So what are the outcomes? So now there's thousands and thousands of POEMs that have been performed across the world. The data has been very strong. In terms of meta-analysis, clinical success rates, 91 to 100%, defined by a lower Eckhart score. Very low rates of adverse events and serious adverse events. And I think one of the newest data that was presented by Stavros Stavropoulos over in Winthrop was the largest single center data in the United States, which I like using United States data because our patient population is different than some of the rest of the world. 700 patients, 9-year follow-up, 92% clinical success rate at 9 years, 0 serious adverse events, 0 mortality, low rates of minor adverse events. And then 48% of patients did have GERD at about 3 years output, and we're going to touch on that a little bit later. One of the main questions is how does it compare to Heller? So this is probably the most quoted study. This is a New England Journal study, a randomized control trial, 221 patients comparing POEM versus Heller at 2 years clinical follow-up. You can see that the clinical success rates were similar, as was the adverse events, although POEM had lower adverse events than Heller. The rates of esophagitis were higher in the POEM group, but severe esophagitis and Demeester scores and acid exposure time were actually similar for both groups. One thing I'll point out here is that the clinical success score for the POEM group was 83%, which is far lower than what you'll see in more modern studies and actually in higher volume centers. And the centers chosen for this study had less than 20 POEM experience in many of the centers being used. So I think this is a low operator volume experience. And I think that number, if you repeated it today at a high volume center, you're going to see a significant improvement in clinical success over POEM for Heller. And then if it was a larger study, some of those adverse events may actually become more statistically significant. If you look at meta-analyses of this, some of them actually show, again, similar safety, similar post-op GERD, and some of the meta-analysis will show higher efficacy for POEM in short-term and long-term clinical efficacy rates, and also shorter operating times and lower length of stay. So there's definitely some tangible benefits for POEM versus Heller. Now let's talk about the elephant in the room, because everybody will ask this question is, what about the rates of acid reflux? Because when you do a Heller myotomy, you're doing a concurrent fundoplication, a partial fundoplication to prevent acid reflux. When you're cutting that LES mechanism, that's what you're worried about long-term. So let's look at the GERD data specifically for United States. And this is the largest study reported by Stavros this past year at DDW. Again, 700 patients, and he did a very, very thorough evaluation of patients for their GERD symptom scores over the course of 9 years. Their symptom score at 38 months, about 51% of patients, so the majority of patients actually had no GERD at 3 years. Less than 1 symptom per week was 32%. The patients with more significant symptoms, 8.7% or 7.2%. Their overall esophagitis rate by endoscopy was 50.9%, of which 70% almost were LA Class A. So really the majority of esophagitis in this patient are mild, and the majority of symptoms are mild. It's less than 20% of patients that have significant GERD symptoms. So many of these patients can be managed with just low-dose PPI and have had similar quality of life scores compared to Heller. Barrett's rates, anti-reflux intervention rates were also significantly low for these patients. But the question is, can we improve on this? Of course, there's room for improvement with any of these techniques. So there's a lot of study going on in terms of what we can do in terms of the technique to improve acid reflux rate. So one of the thoughts is anterior versus posterior POEM. Does that affect the sling fibers and the reflux mechanism? Has not been shown to show any difference so far in GERD. Doing a full thickness versus a partial thickness myotomy has not been shown any difference at this time. Short versus long myotomies, there is a trend towards going towards shorter myotomies. There's conflicting data on this, some studies showing some benefit, some showing not some benefit, although a meta-analysis recently did show some benefit. And then this new concept of doing a POEM plus a fundoplication at the same time. So as you know, we can do TIF as well, and there's data for that for reflux. Personally, I think that is early. And I think that potentially can be very aggressive. You have to predict who may be a high GERD potential after the procedure, rather than doing this on every single patient, because as the data suggests, over 50% of patients have no GERD after 3 years. So if you're going to TIF everybody, you may be TIFing way too many people, and there's always complications with any intervention that you're doing. So we have to try to predict who may be a better candidate for those types of procedures. Also, there's this new anti-reflux POEM that Stavros has been touting, where they kind of preserve sling fibers at the LES. This has yet to be reproduced by other centers, but if it's something that can be learned and reproduced, it may be something that we should be studying in the future. So future directions, things that we're doing at our center, we are using this EndoFlip data device that Dr. Speckler was talking about, where we can measure impedance and the compliance of the esophagus intraprocedurally. So we actually measure the LES compliance and diameter before and after our myotomy in the procedure. We presented our data a couple of years at DDW, and we'll hopefully have over 100 patients now to publish. But we did show that the EndoFlip correlation before and after a myotomy did show an increase in the distensibility by over 4x, and the luminal diameter by 2x, and this correlated with our Eckhart scores. And we're hoping that we can use this over time to predict durability and also potentially predict GERD based on those changes in numbers. We'll move on to Zenker's diverticulum here. So as you know, Zenker's diverticulum occurs just above the cricopharyngeal muscle in Killian's triangle, usually in the 7th or 8th decade of life. Causes various different symptoms: dysphagia, aspirations, regurgitation, etc. And in the past, the treatments used to be a surgical diverticulectomy or a rigid endoscopic septotomy, both of which are morbid and sometimes very difficult to do in patients with limited neck mobility. When you're looking down the barrel of the esophagus from the Zenkers, though, what you'll see is a muscular ridge at the cricopharyngeal bar, and shaving down that bar has shown to be very, very effective. And flexible endoscopic septotomy has been performed around the world for years now. So conventionally, rather than using a rigid scope, but using a flexible scope to get to that cricopharyngeal bar, you can cut it down. And this is just a video courtesy of my friend Nikhil Kumta in New York of how this is being performed around the world conventionally. So here you're looking down at the esophagus. You see the Zenkers on one side and the esophagus on the other side. Often people will put a wire into the esophageal side just to kind of keep your orientation here. He's using an insulated scissors-type knife here to just grab that septum and start cutting the cricopharyngeal bar here. And you can see kind of the esophagus contracting every time he's applying energy here. And as you cut, you can see that cricopharyngeal bar muscle, which is causing the high-pressure zone and causing the Zenkers to form. This technique is nice because it's quite simple in the sense that you can just go down and cut and take care of this high-pressure zone. But because you're cutting right through the mucosa and you're essentially causing a perforation, you're always worried about how deep you should be cutting, or if you're doing a complete myotomy or going too deep and causing a perforation. At the bottom of the cut endoscopist will generally place a clip to try to prevent leakage and bleeding. So this new technique, the data for it is quite good. If you look at meta-analyses of all different types of devices used to do conventional endoscopic septotomy, rates of success are over 90%, but there are some adverse events in terms of perforation and bleeding that can occur. The evolution of this technique has now come to something called Z-POEM, where instead of just working from the luminal side, we actually create a tunnel to access and expose that cricopharyngeal bar. We were actually one of the first groups actually in New York to show how submucosal dissection techniques can help expose the muscle. And then the first Z-POEM was performed a few years ago in China. And here in the Z-POEM, what we're trying to do is expose that bar from inside the tunnel, so when we're doing the myotomy, we can be much more precise and complete without fear of perforation. because we create an intentional perforation ourselves. So here's a Zenker again, and you can actually see that there's some food inside of the Zenker, and this is what's causing these patients' symptoms. And we make sure that we have a clean space to work in, so we're always kind of making sure that there's no contamination from the first to the second space. And so the first thing we do is similar to what we use with the EPOM for achalasia, is that we'll create that submucosal injection so that we can start accessing that submucosal space. So here's, again, just a combination of methylene blue and saline to create that submucosal space just proximal to the bar. And then we're using this Irby knife here to incise into that submucosa. So once we make a cut that's large enough for the endoscope to access, we carefully dissect some of these submucosal spaces, fibers, so that we can enter into that tunnel that we're creating. So now once we're inside the tunnel, the goal here is to expose the muscle and do it from both sides. So we actually have to create almost two tunnels here. One is on the diverticulum side, and one is going to be on the esophageal side of that cricopharyngeal bar. So if here, we're actually dissecting into the esophageal side, and that, all of those wispy fibers in front of us are the submucosa. And we use this knife to inject the submucosa and cut those fibers on that side. We usually go about 2 to 3 centimeters onto the esophageal side and then come back towards the Zenker side. So here we're just kind of cleaning up the esophageal side, and then we're turning our attention over back towards the Zenker side. That's the septum right in front of us, and now we're injecting onto the diverticulum side. We use that methylene blue, and again, to expand it, and then we kind of dissect on the other side to expose all the way down to the base of the diverticulum. And because we're inside of the submucosal space, we actually expose each muscle fiber to itself. So now both sides have been dissected, and the muscle is right in front of us. This is the cricopharyngeal bar, and we can use the same knife, the same tool, to cut right across the muscle here. And every time we use the energy, you can see it contracting here. So now you can see all of those fibers. And now, because I know I have a controlled perforation with my mucosotomy, I don't mind going further, deeper, and more complete with what I'm doing with the muscle here. So this takes a little bit of time to do. It's actually faster than the EPOMs, but we want to be very precise to make sure that we don't have recurrence of this Zenker by not cutting all of those muscle fibers. So here we're continuing to cut and going right across. We're cutting from the Zenker side towards the esophageal side. And then finally, we do a little bit of an extra cut on the esophageal side, about 1 centimeter or 2 centimeters down over to the other side. And now you can see almost no muscle fibers left. It's just a little bit of submucosal kind of wispy fibers, and our septotomy is complete. The last important part is to close your mucosotomy, because that's going to prevent any type of contamination or leakage or infection. And that's done with clips, especially in the cricopharyngeus, where there's not much room to work. We usually don't use sutures up there. Usually some short stem clips will work fine. So in terms of outcomes for ZPOM, in an international series, 75 patients showed very high technical success and clinical success rates, low rates of adverse events, although there's going to be a learning curve for this procedure, and one symptomatic recurrence at about 1 year. One of the big questions we wanted to answer is this better than conventional septotomy? Should we be tunneling or not tunneling for this? So we actually published our data in conjunction with Robert Wood Johnson earlier this year, where we compared ZPOM to conventional septotomy in about 100 patients. The technical success rates were similar, and as were the clinical success rates, and the length of myotomy for the both POMs were fine. But what we found is that the adverse events were lower for ZPOM, and that's partially because of our controlled cut. And also the need for repeat intervention, we're trending towards less for the ZPOM. So I think as in larger studies, more powered studies, we're going to prove that this is going to be the superior method for septotomy. And finally, we'll talk about gastroparesis. As you guys have heard a lot about this today, debilitating motor disorder of the stomach, progressive obstructive symptoms, various etiologies diagnosed by gastric emptying study, and very challenging to manage in all of our practices. There's various different types of treatment algorithms from conservative to very aggressive and surgical. The bottom line with all of them is that we're just not that good at managing it, and it's not as effective, and these are very, very complex patients to manage. And so GPOM did kind of develop in this pathway, because a lot of the interventional things that were being done surgically were not just that effective. And so there's a portion of these patients that do have a component of pylorospasm that's contributing to their outflow obstruction, which we believe that GPOM can help. This first case was performed at Johns Hopkins in 2013. Again, the same concept exists here for Z-POEM, except we're doing this in the stomach. So we start with our tunneling about 5 centimeters proximal to the pylorus. And here, where you're doing this in the stomach, so it's a little bit different. The mucosa is a bit thicker. The submucosa is a bit more fibrous. We have to be a little bit more careful with our tunneling because the stomach is not a tubular organ. It's a kind of a saccular organ. So if you're not directing your tunnel in the right direction, you can go off into the wrong spot. But here you can see us tunneling through this kind of thick, dense submucosa here. And we're constantly going in and out of our tunnel and making sure we're heading right towards the pylorus and dealing with any fibrous stuff. Also, the tunnel here will have larger blood vessels because the stomach does have larger blood vessels. So we're always making sure that we're controlling any bleeding inside of the tunnel for the G-POEM. And so we're just kind of going through the tunnel here. But once the tunnel is complete, you'll run into this ridge of muscle right here, this white ridge of muscle, which is your pylorus. And the pyloromyotomy only needs to be about 2 to 3 centimeters. You have to be very careful you don't go too far because you don't want to perforate or hit the duodenal side. But we often use an insulated tip knife to create a full thickness 2 or 3 centimeter myotomy. Clean the tunnel again with some holy water. And here we try to we suture it closed usually with because of the clips being so smaller in the stomach tissue. So in terms of outcomes for G-POEM, pooled analysis of 144 patients showed a high technical success. The clinical success is measured by a GCSI score, which was alluded to earlier as a symptom index, showed 81.5% improvement of symptoms, gastric emptying normalization in 55%, and low rates of adverse events. A more recent meta-analysis of 292 patients, again, showed symptomatic improvement in 89.3%, low adverse events. I think that this has to be taken with a grain of salt because long-term clinical efficacy ranges, between 56 and 81.3%, and these are just complex disorders, and there is going to be a learning curve for this procedure. The take-home points here is that third space endoscopy is offering minimally invasive options for foregut disorders that really never existed before and help avoid surgery. POEM is now at the forefront for third space endoscopic techniques and is quickly becoming first-line therapy for multiple diseases, including achalasia and Zenker's diverticulum. I think that GERD rates after EPOEM are significant. However, the vast majority of it is mild and easily managed with PPIs. And Z-POEM is effective and maybe safer than conventional septotomy techniques. And in the end, G-POEM is effective, but its role in evolution really requires more study to predict who's going to be a responder to this technique. So I'll end with this picture of a tunnel and this quote, that when a train goes through a tunnel, it gets dark. You don't throw away the ticket and jump off. You sit still and trust the engineer. And I'll say that this has been this development of this technique has been quite a ride. And I'd like to thank my mentor, Michelle Cahaley, who was there for our first POEM years ago here in Dallas, all the way to this past year when we hit our 100th POEM. And I thank everybody here for their time and their attention. Thank you.
I think we definitely trust the engineer. That was fantastic. Can I ask our speakers to come up? We've burned through some of our time, so we're going to cut this question and answer panel to 10 minutes. If we can get 10 minutes on the clock, please. And I ask all of our attendees with questions to come to the mics on the floor. We've got one in each aisle. I would encourage you guys to come forward now with questions, please.
Everybody's stunned.
Dr. Wilson, I presume.
Overwhelmed.
Congratulations. What a fantastic session. Thank you all so much. Dr. Lacey, this cannabinoid hyperemesis we've been dealing with, it's difficult. Is there any evidence, or have you used clinically CBD products in those patients or encouraged them? And there's a lot on the internet about that. I wanted to ask about that.
Yeah, so what a mess, right? And we know so little. So I think the teaching points are, one, remember there are two types of cannabinoid receptors, CB1, CB2. They're in the GI tract and in the brain. They're affected differently. Number two, we know so little about this, and CBD comes in so many different forms. And so it's very hard to do good studies, even epidemiologic studies, because your patient in Texas is using one form versus Florida at different doses, et cetera. Number three, we do have some data showing that cannabinoids and slow stomach emptying. We also have data that's not published but is now in the public domain from a very large study in IBS patients that it does not seem to improve pain, contrary to public opinion. So patients will tell you this works for things, but we really have no good data. Your one question you asked was, could you maybe transition people off marijuana to other products? We just don't know because we really don't know how they work. And a lot of this may be the placebo effect, right? Placebo is pretty powerful. That said, I'm looking around the room for younger people. Remember, this is stored in fat cells. So when you tell your patients to come off cannabinoids, it has to be 60 to 90 days. And when stored in fat cells, it'll leak out. So when you do that urine study 60 days from now, if you've been socializing, it'll still be present. So be careful.
Excellent. Dr. Tao over here.
For Dr. Kedia, how do you choose or try to predict who's going to respond to the GPOM procedure? For example, can you use a Botox injection and the person who responded to that mechanistically might be a good candidate?
Sir, so that's a great question. So there are some studies out there looking at predictors of response to GPOM. They're not high-quality studies. Some of them have shown that actually diabetics, females, high opioid use, psychotropic, psychologic manifestations of disease are negative predictors to response. That being said, I wouldn't exclude all of those patients by any means. I do look at their symptomatology index and their GCSI score. If they're more along the pain area of that scale, I will tell them that this procedure is probably not going to fix your pain symptoms. It's mainly for obstructive symptoms. So I try to gear my procedures towards obstructive phenomenon. That being said, I do use Botox injections pre-op for patients that are not really slam dunk cases or I'm not really too sure about, and that I kind of want to rule out the crazy, in some patients. I use a Botox injection and say, did it work for you or not? The data for Botox and gastroparesis has been shoddy. Right. And I think a lot of that is operational variation. For me, I have been doing 100 units of Botox in those patients that I'm trying to predict for, and in 4 quadrants. And within 1 to 2 weeks, I'll have another clinic visit with them and say, did you respond? And usually within at least a week of that Botox, they should have had some response to it. If they don't, I will say that the chance of a GPOM helping you is probably low, and we'd have a very serious, detailed discussion about whether we would do that. But if they have a slam dunk response and they say, hey, for 2 weeks I felt great, and now the symptoms are coming back, I'm much more comfortable proceeding with the GPOM for those patients.
Makes a lot of sense. Thank you.
Wonderful talks from all the panelists. I thank you very much for your insights. But question for Dr. Speckler and Dr. Kedia, I guess, in terms of the new kind of the Egj outflow obstructions and hypercontractile esophagus, do you see a role for POEM in treating these conditions?
I'll take it first and then give it to Dr. Kedia. There definitely is a role. Now, what happens here is we have a kind of a double-edged sword, okay? Because when you have a hypercontractile esophagus, that can be a primary disorder, or the esophagus can hypercontract because there's obstruction low down. There's Egj outflow obstruction. So a priori, you're not sure. If you have a patient with both hypercontraction in the body and an Egj outflow obstruction, you don't know that hypercontractile esophagus would go away if you just relieve the distal obstruction. So we have started a policy of pretty much starting just with pneumatic dilation for the Egj outflow obstruction in that case, not going straight to POEM. Because remember, all our procedures, all our invasive procedures to care for achalasia and for outflow obstruction, they're designed to destroy muscle. I mean, they're destructive procedures. They virtually eliminate any possibility of ever restoring normal function to that esophagus. All we do is alleviate the symptoms, and it works pretty well. But, don't expect things to be normal. So I don't usually start with the POEM in patients with Egj outflow obstruction. I'll do the the pneumatic dilation first. We can argue about whether that's any safer, but at least it doesn't destroy muscle in the body of the esophagus. Now, the patients who have hypercontraction as a primary disorder, they will probably need a POEM. And that's one of the beauties of POEM, is it does give you that long myotomy. But remember, with Egj outflow obstruction, you had some preserved peristalsis. Now you're going to get rid of that, right? So, you just have to balance all these things, and we still don't have good studies to say what we should be doing exactly.
Yeah, I agree with Dr. Speckler that this is a kind of a vague area. There is study out there on there's a meta-analysis that just came out on Egj outflow obstruction with POEM, showing good results. They had over 90% response. But again, I think that pre-op workup is extremely important. Like, you can't just go based on a high IRP and normal peristalsis. You need an extra study like a barium esophagram or an endoflip, which we use routinely to prove that there's an obstructive phenomenon going there and that there's not something extraluminal, cancer, some type of other disorder that's causing this. You want to make sure this is a pure LES hypercontractile issue. The data for DES or nutcracker or the hypercontractile esophagus is not as good. The outcomes with POEM for that are somewhere in like 75 to 80% in terms of response, and it's more for pain and odynophagia, dysphagia for those patients. And so I think that our efficacy in that population is needs more study, and we need to have better predictors of who's going to be a better responder for those. We do use a lot of pneumatic dilation to start predicting who's going to respond. There are some patients, if they're slam dunk, look like early echolalia, Egj outflow obstructions, and classic, bird beak, sometimes we'll go straight to POEM, but it's a case-by-case basis.
I just add one more thing to that. One of the complications that we're seeing now that we probably didn't see as much in the past is called blown out myotomy. BOM is the term for it, BOM, blown out myotomy. And I think the reason we're seeing it is because we're doing these procedures at the EG junction in patients who still have contraction in the body of the esophagus, like Egj outflow obstruction or hypercontractile esophagus. Now, when you make a myotomy, you got this thing contracting above. Now you can blow that out, and that's actually a bad outcome. It's not an acute event. It happens over a period of time. But a lot of those patients, if that develops, they might even require esophagectomy for that. So, you have to put that into the equation also. It's how long do you make that myotomy? When do you go to POEM? When do you go to pneumatic dilation? The reason we start with pneumatic dilation now is people have not seen BOMs, blown out myotomies, after pneumatic dilation, so we prefer to start with that.
Fantastic, thank you.
We've got a couple online questions, and I'm going to try and consolidate them just in the essence of time. So one of the questions is about PPI dosing, and so probably both of you guys can speak to that, because I know that you had said maybe once a day is adequate. The question is, for example, 20 milligrams versus 40 milligrams, and if we're doing 40 milligrams twice a day, is that not the right dose, because some of the studies were 20?
Yeah, I'll just briefly mention, so most patients don't need twice-a-day PPI therapy. That's the bottom line, and Dr. Speckler has a lot of data on that. So generally for most patients, once-a-day therapy is adequate, and if they're having symptoms, you should see, are they still having reflux?
Yeah, no, I absolutely agree. And, I see so many patients who come in on 40 milligrams twice a day. The FDA-approved dose for reflux esophagitis is 20 milligrams once a day. So 40 milligrams is actually already a double dose. 40 twice a day is a quadruple dose of the drug, and most of the time it's just not necessary.
So for Stu, I guess, and this is offline, but the question is, they want to know how they can refer patients to Baylor. So since we're Texas, but for your esophageal department. And then I guess just as a consolidation question, so they would like your thoughts on, is POEM, does it need to be done under the protective umbrella of an academic center, for y'all's opinion, but also is it something that's accessible for all three types of achalasia, or maybe just Egj outflow obstruction?
Well, it's been used in all three types, and it's a good procedure, and I don't think it has to be done in an academic medical center. We'd like to do it in an academic medical center, but I don't think it has to be done. But, one of the things that I am a little concerned about POEM is that, achalasia is increasing in frequency, but it remains a relatively uncommon disease. So I wonder where people in practice situations are getting all these patients to do all these cases of achalasia. I think if you have a good person in your local hospital, that's fine. No, I don't think it has to go to a specialty center, but I think you have to know how good your people are.
Yeah, I agree. We're not a fully academic center. We're a kind of a hybrid model in our hospital. So I think that you have to have an endoscopist with excellent training and also a trained staff and all the resources and backup at your center, right? You don't want to start a PROM program or third space program without adequate surgical backup and adequate credentialing processes at your hospital. And this is an evolution with our societies on how to establish all of these. So those are very important. And in terms of all types of achalasia, it's been shown to be effective in all three types, and actually may be more effective for type 3 than Heller because of the length of the myotomy you're able to get proximally compared to a peritoneal access point. So I think so. It's effective for all three.
So I think we probably don't have time for more questions just so we can stay on schedule. If you have questions, if you want to come up and ask, and we have a break scheduled, if we could probably restart about 10:35 and we'll slowly work our way back on to schedule, that would be great.